My name's David Kerr, Professor of Cancer Medicine at University of Oxford. I'd like to talk about a study recently published in Lancet Oncology, which is of particular relevance to my clinical practice, and I hope of general interest to you, our Medscape colleagues. It was a trial published by an excellent Dutch group, and it was called the Collision Study, Thermal Ablation versus Surgical Resection of Small-Sized Colorectal Liver Metastases. This is important. We know that 20% of patients with colorectal cancer will present with hepatic metastatic disease, and more than 50-60% of patients will die with hepatic metastatic disease. And we become much more rigorous, aggressive in our management of hepatic metastatic disease. And my favorite clinical meeting of the week is with our liver multidisciplinary team, supported by fantastic surgical colleagues and by a radiological ablationist. So this Dutch trial compared the two. The gold standard is to surgically resect hepatic metastatic disease if technically possible. But that comes with significant morbidity, costs, and so on. And there's no doubt improvements in thermal ablation, the possibility of passing electric current down a sort of fine electrode inserted into the nodules and effectively burning them out. The technology has improved, as have the results, and as has safety. There's a degree of confusion in the literature with, I think, rather flawed meta-analyses comparing chalk with cheese, as is sometimes the case when we look at meta-analytical data. So having this prospect of randomized trial comparing thermal ablation and surgical resection is welcome. The patients that they selected were they say small size, so it would be 3 centimeter. The nodule size in the liver would be 3 centimeters or less, but you're allowed to have up to as many as 10 separate nodules, so a significant disease burden. Excuse my cold. They powered the trial based in non-inferiority. Now, there's a whole separate Medscape video we could do about non-inferiority, and they set their hazard ratio at 1.3. That's quite a big margin. They plan to recruit 600 patients, but as a planned interim analysis after around 30 months, with 300 patients recruited, they found that they had met their trial endpoints. And what they demonstrated in brief was that thermal ablation was indeed non-inferior to surgical resection, but that it was safer with significantly reduced and fewer side effects, just generally less dangerous. And therefore it makes a very reasonable case that our capacity to personalize, individualize hepatic ablative modalities is now equipoised and up for discussion. So depending on age, infirmity, comorbidities, etc., I think there's a very good case that we could make for thermal ablation. Now, in the trial, a number of patients in both arms, actually, some underwent predominantly resection and ablation of perhaps one lesion that was not surgically resectable. And the same with thermal ablation, because of the geography of the metastatic nodule, surgical resection was had to be applied. So there's a bit of a sort of mixture in a relatively small number of patients. And again, that's about tailoring the treatment to the individual. One may say that it would be possible to resect the majority of disease and then ablate a couple of residual areas, or on the other hand, thermally ablate the majority of disease, but perhaps with limited surgical resection in those areas in which the ablationist couldn't quite sensibly reach. So it's a really nice study, an excellent group. These were very highly trained centres. So again, the other plea that I would make is that for those patients who have undergone chemotherapy, who've got potentially resectable disease, please refer them to your local regional network centre, which has got the necessary skills and expertise, surgical, radiological, chemotherapeutic, refer them to these specialised centres whom I think would be in a position to offer the patients the best individualised deal. There are 10-year survival rates now of somewhere between 18 to 24% for patients in whom we manage hepatic metastatic disease aggressively, but with the right teams at the right time in the right place. So a lovely trial. It confirms, which many of us believe, but it's always good to have the evidence, and a plea that we should have more of these regional centres with strong referral pathways so that patients get the very best deal that they can. I'm very keen to hear any of your comments or anything else that you'd like to post, but for the time being, Medscapers, over and out. Thanks for listening as always.